of PPH as well. So thank you so much, Dr. Saili. And we move on. We move on to the next speaker now, and our next speaker is Dr. Amit Kavimandan. He's got a mind-boggling CV. He's done his MBBS from KEM Mumbai, MD Medicine from AIMS Delhi, and DM in Gastroenterology from AIMS Delhi. He has a number of publications and poster presentations to his credit, and awards in galore, I should say. Just to name a few, I would say they are Rajay Bahadur Heart Foundation Gold Medal, Shatayushi Best Medical Student Award, MUHS Gold Medal, Dr. Shivarkar Prize, Waghbhat Memorial Prize, and the list goes on. So I wonder how one person can achieve so many gold medals in such a short span of time. That's really great, Dr. Amit. And over to you for your talk. And he's got a very interesting topic today, and the topic is non-alcoholic fatty liver disease. Yes, over to you, Dr. Amit Kavimandan.
Thank you, ma'am. Am I audible? Am I audible?
Yes, yes.
Okay, thank you. Thank you, ma'am, for such wonderful introduction. And thank you, IMA Executive Amravati, ADC, Dr. Vikram, for giving me this opportunity. So I'll share my screen now. Okay, so what we're going to talk about today is emerging, I would not say an emerging, it's already an established pandemic in along with COVID-19. It's a very, very serious disease which our country is facing. And the unfortunate part is that many of us are not aware about the disease. So fatty liver, you must have heard it about many times that ultrasound was done for some other reason and you found out that there was fatty liver. So we always think that it's a minor innocuous disease, but that is not the case. So what is actually fatty liver disease? It's accumulation of fat in the liver in the absence of recent or ongoing intake of amount of alcohol, because alcohol also causes fat deposition in the liver. So if somebody is having fat deposition in significant alcohol intake, so obviously the question is going to arise, what is the significant alcohol intake? And that is everybody is going to ask, so mere liye kya safe hai? So cutoff is up to 20 grams per day. So in layman terms, 10 grams of alcohol is present in 30 ml of whiskey or 100 ml of wine or 250 ml of beer. So anything more than 2 drinks is significant alcohol intake. Also, there are some other secondary causes like hepatitis C infection, bariatric surgeries, TP, and some medications, and some inborn errors of metabolism which can cause fatty liver disease. So there's a spectrum of NFLD, non-alcoholic fatty liver disease. Commonly what we see is a simple fatty liver called steatosis. There is just accumulation of fat in the liver. Then this fat causes inflammation and fibrosis. This is called as non-alcoholic steatohepatitis. There is fat, also there is inflammation. So this is NASH. This is the second stage. And if this remains unchecked, next comes is cirrhosis. There is the loss of hepatocytes and the scar tissue is replacing the normal hepatocytes. That is the deadly end of this disease. So how common is NFLD? You'll be surprised to know it's fairly very common. If you can see in this graphic, it has been seen in various studies that NFLD comprising all, that is steatosis, NASH, cirrhosis, can be seen up to 30% of normal Indian population. Out of these 30% patients having steatosis, 7% can have NASH. Out of these 7% of patients having NASH, 25% can have NASH-related cirrhosis. And out of this 25% cirrhosis, 60% can develop liver failure, and almost 20% of them can develop a malignancy in the liver, that is hepatocellular carcinoma. So it's a serious disease. So what are the risk factors for NFLD? We all know obesity is the major risk factor. Diabetes, again insulin resistance, then abnormal lipids, that is low HDL, that the good HDL is low, and high triglycerides. You can see all these are interlinked. Insulin resistance causes diabetes, obesity causes insulin resistance, and All of these combine together to form low HDL and high triglycerides. So all of these are important risk factors for NFLD. As I alluded to earlier, the prevalence of fatty liver, that is simple steatosis, seen on ultrasound is very high in Indian population. You can see the blue bars are urban studies which have shown that almost 30% of urban Indian patients have steatosis if you do their ultrasound. These are, mind you, asymptomatic patients. And if you do the same study in diabetic patients, this percentage can go up to 88%. And not only that, we might think that obesity, diabetes, all these are problems of urban patients. No, this is quite prevalent in rural population also. There is a study from West Bengal, supposedly a poor state where the rural people are poor, the BMIs are low. Even they found out that 10% of population there, asymptomatic general population, had fatty liver disease. So that is very alarming. And studies have shown that Indians are more prone to NFLD. Uh, it has been seen earlier also that Indians have lower BMI cutoffs for obesity. If you all know, Western cutoffs for obesity are different. Indian cutoffs for obesity are different. We have obesity at lower BMIs also. So, and it has been seen that patients who are not obese in India can also have fatty liver disease. We have very high prevalence of diabetes mellitus. We are going to be soon the world capital of diabetes. We have very high central obesity, high insulin resistance. We have very high hepatic triglyceride concentration. And as I said, 8% of patients of fatty liver disease are lean. They are not overweight, they are not obese. So that is very risky. So, and NFLD is just the tip of the iceberg. As we saw earlier, insulin resistance, obesity, diabetes, all are interlinked. So, NFLD, if you see, patient is underlying having a metabolic syndrome, insulin resistance, hyperinsulinemia, central obesity, dyslipidemia, hypertension are all going to be there beneath the surface. So how do they present? They are mostly asymptomatic. Sometimes they can present with right upper quadrant pain, which may be vague. They may present with fatigue, or if somebody is unfortunate that he's already developed cirrhosis, they may present with complications of liver disease like GI bleeding, ascites, pedaledema, or encephalopathy. Also, they may have associated other complications of metabolic syndrome like obstructive sleep apnea. Obstructive sleep apnea is a very poor prognostic marker of overall metabolic syndrome also. And they may have complications of metabolic syndrome like hypertension, coronary artery disease, kidney diseases, strokes. So they may have. So how do we evaluate? If you do a liver function test, most of them will have normal liver function test or mildly elevated SGOT, SGPT. We have to rule out other causes of liver disease like hepatitis B, hepatitis C. Autoimmune liver disease can also cause sometimes fatty liver or abnormal LFT. And in fatty liver disease, 30% of patients can have positive anti-nuclear antibodies, but they are usually low titer antibodies, and these are false positive antibodies. Other workup may show increased ferritin. Again, this is showing increased ferritin is related to inflammation and insulin resistance. So on imaging, see, the commonest way a patient is diagnosed as fatty liver is by doing an ultrasound. So fatty liver is seen when the fat occupies almost 30% of the hepatocytes. Commonest imaging modality performed is ultrasound. And as we all know, you have seen the reports, grade 1 fatty liver, grade 2 fatty liver. Grading on ultrasound is not associated with severity of inflammation or fibrosis. So that is just a subjective assessment. Also, CT abdomen is a very sensitive test to diagnose fatty liver, but it is costly and causes radiation exposure also. And MRI with spectroscopy and elastography, it is best for assessment of fatty liver disease, but it is highly costly and obviously time consuming. So how do we diagnose? The gold standard for presence of, just presence of steatosis does not mean much. You have to detect inflammation and fibrosis. So to detect inflammation, the gold standard is liver biopsy. You have to put in a needle inside the liver, take out the liver tissue and examine it under your microscope. It is important to differentiate between steatosis and steatohepatitis. So on liver biopsy, we may see macrovesicular steatosis occupying at least 5% of the hepatocytes, but obviously it is highly invasive. Patients can have complications, pain, bleeding, sometimes bowel perforation, and you cannot do liver biopsy again and again. Like you have done a liver biopsy for diagnosis, you give some treatment and you want to see improvement. The patient is not going to come back to you if you say that I want to do liver biopsy again. No way. Again, liver biopsy, it depends on where you do. So there may be sampling bias. Sometimes the position where you've done the steatosis may not be severe, inflammation may not be severe. So we are looking for something non-invasive tools for assessment of NFLD. So the important tool which has become available is called as transient elastography with CAP. So this is basically a ultrasound-like test called as commonly known as fibroscan or a fibro test. What we are doing is, so basically what it does is it gives passes a sound wave through the portion of liver, and the reflection of the sound wave is calculated, and the time taken for this reflection gives us the assessment of stiffness of liver. If there is fibrosis in the liver, liver becomes more stiff. So more stiff liver, more fibrosis. So it gives us a measurement of liver stiffness measurement, and it is directly correlated with fibrosis. There have been multiple studies over the past, say, 10 years or so, that they have done liver biopsies and done fibroscan, and they have shown that it correlates very well. And also an addition is that new method is added, that is CAP. It gives us the level of steatosis, how much fat is in the liver. So it is basically measures the impedance, acoustic impedance of the liver. So this is the very handy machine that we have at our hospital also. We're using it regularly. So you can do a fibroscan. It's a non-invasive 5 minutes procedure like an ultrasound. You put the probe on the intercostal space on the right side where the liver is located. You take 10 readings and the machine gives you an average of the readings, and we can assess the fibrosis. So the report comes like that. We get the stiffness. So stiffness is here, and this is CAP. This is the assessment of fibrosis. And we have the scale also, like I'm going to talk to you in the next slide. So this is the correlation between the fibroscan values and the histology. So the histologically, the fibrosis is classified from F0 to F1. F0 is there is no significant fibrosis. F4 is cirrhosis. So we have the values of fibroscan correlate with this levels of fibrosis. So if the fibroscan value is below 7, there is no significant fibrosis. 7 to 9.5 is significant fibrosis. 9.5 to 12.5 is severe fibrosis, and 12.5 and above is cirrhosis. So within 5 minutes, we can detect whether this patient has fibrosis. As we seen earlier, steatosis is very common. It is very essential to detect fibrosis because that determines the prognosis. These patients are likely to go into cirrhosis and liver failure and complications of cirrhosis. So this is a very good non-invasive tool. It is widely used and validated. It is fast, reliable, reproducible. It is very accurate. It can exclude cirrhosis and give a prognostication, and can be used in children also. Obviously, liver biopsy very difficult to do in children, and it can be used for screening also. Like in diabetic patients, we've seen 88% of have fatty liver disease. So if you want to screen such patients, this is a very good tool because they are likely to develop complications. So we have diagnosed, we have assessed the level of severity, fibrosis. So how do we manage NFLD? Management is very important. And the most important, we start from the base of the pyramid, is lifestyle modification. We have to target the metabolic syndrome. We can use some liver directed drugs and manage the complications of cirrhosis. So the crux of lifestyle modification, as you can see in this graphic, the most important, the biggest circle I put is exercise and physical activity. That is the most important thing to manage fatty liver disease. If you reduce weight, do a regular exercise, your lipids will improve, insulin resistance will go. Even if the patient is not able to lose weight, but he is doing aerobic exercise at least 45 minutes to 1 hour every day, there has been shown to be improvement all the biochemical parameters, insulin resistance, the triglycerides, even if you are not able to lose significant amount of it. So that is very important. energy restriction, reduce caloric intake, avoid sugar and alcohol. Patients who are taking alcohol also, it is very essential to stop, because alcohol are all empty calories and alcohol will also damage the liver. And not only that, patients who are not taking alcohol, sugar is like alcohol. Sugar is as dangerous as alcohol, so it should be stopped. Even for others also, sugar is as dangerous as alcohol now, and it has been shown to be addictive also, as addictive as alcohol or some other drugs. And we can add micronutrients also. They are very essential, like zinc, selenium. These micronutrients decrease the inflammation, decrease the fibrosis. An important thing is, coffee has been shown to be very beneficial to decrease the fibrosis and inflammation in liver. But coffee should be taken black, not with sugar or milk. Then we are decreasing the all beneficial effects of coffee. Coffee has a lot of antioxidants which are very useful. Then we've seen patients, we've given them lifestyle modification, then we use drugs. When to use drugs? We should not use drugs in every patient. Patients who are having significant fibrosis, that is fibroscan values above 7.3 or 7.5, we can use drugs. Or patients who are at high risk of progression, like who are more than 50 years of age, are having diabetes, are having abnormal LFT, drugs should be used. So what drugs are available? The commonly used drug for fatty liver disease is vitamin E. It was a landmark trial called PVENS trial, which has shown that almost 800 milligrams per day of vitamin E was useful in non-diabetic NASH. But other studies have failed to reproduce the similar results. But yes, as a starting drug, vitamin E is a good drug to start in NFLD, just has mild to moderate effects. But it has some complications, like it can increase cardiovascular mortalities, can cause hemorrhagic strokes, and some studies have also shown association with CA prostate. Other commonly used hepatoprotective drugs like ursodeoxycholic acid is not useful, commonly prescribed all over, but it is not useful in fatty liver disease. Anti-diabetic drug pioglitazone has been shown to have beneficial effect on fatty liver disease, but the problem with it is it causes weight gain, so it is counterintuitive to the management of NFLD, and it also increases the cardiovascular risk. The S-adenosylmethionine, it has good animal studies data, but clinical studies data is not so good. Probiotics, silimarin, there are no data that they are useful. We have some newer drugs which have become available to us recently. One of the drug is enoxaparin.
Hello, Amit sir. Hello, Amit sir.
It is already approved for management of was I disconnected?
Yes, sir. Your network connectivity is not so good, so you was disconnected, sir. Please kindly start the screen sharing again, sir.
Okay. So okay. So did we hear about the, should I start again, or should I start from this slide only?
Start from this slide only, sir.
Yeah. Okay. So this drug it is safe and well tolerated. Its phase 3 study is ongoing. Another drug, that is elafibranor, it is dual
Sir, I
PPR
kindly
alpha and
request you
delta
to switch off
agonist.
the
It is
video.
also safe and effective. Phase 3 study is going on. Switch off the video. Okay.
Okay.
Better. So a
Yes,
new
sir.
drug.
Yes, sir. It is good, sir.
Okay. Thank you. So a newer drug newer drug which has become available, that is obeticholic acid. It's a farcenoid X receptor agonist, and a recent randomized control trial showed that it is causes significant reduction effects on insulin resistance and lipids, also causes in India in the past 6 months or so, and the results are encouraging. There are other anti-diabetic drugs which are incretin-based drugs like liraglutide, ifraglosine. These are also useful in management of fatty liver disease. And as we all know, weight reduction is very important for management of fatty liver disease. Patients who are not able to lose weight by exercise and diet control, the options are bariatric procedures. Either they can be done surgically or endoscopically. Also now we can put endoscopically intragastric balloons, or we can do a DJ sleeve bypass, or we can do an endoscopic gastroplasty. So these have shown good effects in management of diabetes also and fatty liver disease also. But the problem is that patients who are already developed cirrhosis, those have high risk for undergoing bariatric procedures. They may develop liver failure post bariatric surgery, and sometimes the earlier bariatric surgeries were using fat vitamins. So how is the prognosis? As we say, steatosis can progress in 50% of patients over a period of say 15 years. Out of this NASH, 50% can develop cirrhosis over a period of next 15 years. And once you develop cirrhosis over a period of next 10 years, 20% can develop liver failure and hepatocellular carcinoma. And as we've seen here, the progression is reversible if you arrest it at NASH. You can go back to steatosis and normal liver. But if NASH progresses to cirrhosis, then it is irreversible. So very important to identify patients who are in this stage, and you should be able to go back by treatment and lifestyle modification. Also, these patients have high risk of cardiovascular morbidity and mortality, and there are higher chances of developing diabetes mellitus. Anybody who is detected to have fatty liver disease and is non-diabetic over a period of next 8 years or so, 20% of them develop diabetes. The hazard ratio is as high as 4.8%. So very important is to selectively. And NFL country, I think it would be something like a second or third commonest cause of cirrhosis now. I thank you all for your patient hearing, and I thank you again. Thank IMA executive body and Dr. Vikram for giving me this opportunity. Thank you.
Thank you so much, Dr. Amit Kavimandan. It was a wonderful talk, and your talk really reflects that you are a true genius. It was in depth, and you have given us very practical tips also, especially regarding that sugar is, as dangerous